Greetings and welcome to another edition of Montpelier Connection. I'm Mike Mrowicki, the state representative from the Windham 4 district of Putney, Dummerston, and Westminster. As the election has gone by now, we are getting ready for the 2015 legislative session. We'll be starting to take a look at some of the really prominent issues that we'll be addressing in this next session of the legislature. As someone who sits and has been sitting on the House Human Services Committee, over the past few years we have done a lot of work. Some of it we've been forced to do because of the closing of the state hospital, but we've been working on mental health services. We understand, we've begun to understand more and more how important this is to the health of our communities, how important it is to get mental health services, to get addiction services out to the public more. And so today's show will be focusing on the mental health services that are available here, right here in Brattleboro and Windham County through the Brattleboro Retreat. And we're pleased to have Dr. Robyn Ostrander here. Did I get your name right?
You did. Thank you, Mike.
Usually it's my name that gets mispronounced, so I try and be careful about how I do with other people's names. So welcome.
Thank you.
Yeah.
So I'll tell you just a brief thumbnail about myself. I'm Robyn Ostrander. I'm a child psychiatrist, and I've been practicing in Vermont for my entire medical career. Came here from Boston in the year 2000, so 14 years now. I'm a transplant from Wisconsin, but been in Vermont, been in New England since college. And I'm a child psychiatrist by training, as well as an adult psychiatrist. My position is senior medical director at the Brattleboro Retreat, and I've been there for about 7 years.
Now, when you say child psychiatrist, what are the ages that you treat?
Well, child psychiatrists treat all ages. So the way that training is structured is that everyone who wishes to have post-medical school training in psychiatry learns adult psychiatry, and then those who wish to further specialize add on children and adolescents. In my daily work, I would say that I focus almost exclusively with teenagers, although I do work with kids who present to the retreat at any age, but uncommonly under age 6.
Now, the retreat is the state's designated hospital for children. So any child in Vermont who needs services will come to the retreat?
That is often the case. There are a few locations where people can have crisis stabilization, and occasionally there are times where Vermonters are sent to neighboring hospitals in neighboring states, like Plattsburgh, New York, occasionally. But largely we serve the children and adolescents of Vermont who require hospitalization, who have Medicaid. If they have private insurance, they have choice, but we serve many children from Vermont, New Hampshire, Massachusetts with private insurance as well.
The retreat's doing some great work here in Vermont. And I hope we can express our appreciation starting with the day after Tropical Storm Irene, when literally we loaded up a busload of patients from the state hospital, and the retreat took them in. And since then, you've been populated. Your regular population has been augmented by the state patients, and we really appreciate that. All the work that you've been doing to help the state, you really helped us out in a time of need, and appreciate that the retreat really stepped up. One of the things I appreciate that the retreat is doing now, out of all the good work you're doing here, is your campaign now, Stand Up to Stigma. I think this is an important issue. As a layperson, I appreciate that this is a subject a lot of us don't know a lot about. My own way of looking at it is that most of us have some mental health problems over the course of our lifetime. It can run from, let's say, a cold to cancer. There's some deep problems that we need help with. Stigma often gets in the way of people getting to treatment, though, isn't it?
Absolutely. And because there are so many effective treatments for illnesses like depression, it is really important, in our view, to try to figure out what are the barriers to getting into care. Because if you take depression as an example, within 6 to 8 weeks of treatment, and that could be therapy or medication or both, 80% of people are noticing significant improvement. And yet, only a very small fraction of those with depression seek treatment. And those who are in treatment don't often stay. And we wanted to explore and address and really fight as much as we can some of those barriers we believe are related to stigma.
Yeah. I think these societal barriers, the stigma that gets put up, are just from being oblivious to the options that are out there, the benefits, and how we look at mental health. I know as a member of the Quaker congregation in Putney, we talk about our history, and the history of Quakers is that about 100 years ago they became great advocates for changes in mental health treatments. They were down in Philadelphia, some of the first advocates to say, let's unshackle these people because it's not helping anybody, it doesn't help us either. We've come a long way from shackles and cages, but those barriers are still there. Do the barriers run more to one gender or the other? Do you see more?
I think they're different. If we, just to run down the list, what are those barriers? Like you said, lack of understanding. So if I were a person suffering with depression, for example, which is the most common mental illness, 20% of us in our lifetime will have an episode of depression, which is a significant episode, not a day or two of feeling blue. Yeah. So let's say that I'm a person with depression. I, first of all, would have to decide that treatment would be something I would want to go after. So why would I want to do that? I'd want to feel better. Why would I not? Well, if I seek treatment for depression, which goes into my medical record, then the next time I wish to reinstate or renew my life insurance, I will pay a lot more money. Because actuarially, someone will assess that I'm more likely to die by suicide and I will pay higher rates. That's just a reality. It is not fair. The same is true if I disclose that I smoke cigarettes. That also goes in. But people do think about that and will not seek treatment for that reason. I may have to tell a loved one that I have depression, which often brings a lot of shame, as if it is something I brought upon myself, as opposed to what I see as the reality, which is that my brain is an organ in my body. Yeah. It's actually in charge. We know now that things like depression and other psychiatric conditions don't come from evil humors or, hysteria, a wandering womb. They just don't come from odd places. They come
demonic possession.
Exactly. They come from our brains. Yeah. And if my pancreas were acting up, I would go to see the doctor. I don't see very well, so I wear contact lenses. I don't tell myself that I should gather some internal strength and overcome my visual disability. I just wear glasses or contact lenses. And I see accessing psychiatric treatment as that. Why would I not want to access something that could help my brain work better and function better? Some of the other stigmas are around, what will my family say? Will they support me? Will they not? What will my employer say? For example, it's much easier to say to your employer, well, I have cancer and I have to have treatments, and they're going to be, every Friday afternoon for 4 weeks. Imagine the response I'd get. I'd get sympathy, I'd get offers of support. If I said, well, I have severe depression and I have to go to a special group that's going to help me function better, and it's going to be, every Friday afternoon for 6 weeks. I don't know what kind of response I'd get. Some enlightened employers would be supportive. Others might think, well, it's a mark against me. Stigma comes from the ancient Greek meaning mark. There's my mark. I'm now marked as an employee that maybe isn't quite up to snuff. Yeah. So there are real reasons not to. I didn't speak to the thought about gender, though. Yeah. Did you want me to talk more about that?
Yeah. Yes, in a couple of ways. Do more men seek treatment or more women seek treatment?
More women seek treatment.
Yeah.
You have to look at the reasons why people seek treatment. There are some conditions where there is a real significant disparity in gender. For example, there are more women with major depressive disorder, about 2 to 1. There are more males with ADHD and autism. Mm-hmm. There are reasons why people choose to seek treatment. You know, children will seek treatment because their parents seek treatment for them. So there tends to be not so much of a gender disparity. You could argue that in our culture, women are less discouraged from looking for support, either from their friends or even from the medical community, although there are certainly many, many women who keep, for example, their depression to themselves and just suffer without telling anyone. I think there are more cultural biases or sort of, I don't know, reasons why men need to be strong and really infallible or not to be seen as weak in any way. And going to a health provider at all can be seen as a weakness. There are people who won't get a physical, will rather die of colon cancer than have a colonoscopy, you know, not get a prostate exam. I mean, there are many things that we feel are weak, shameful, we'd just rather not talk about it. And there are unnecessarily deaths and disability because of that. So I think it is harder for men to admit that they could benefit from treatment. And yet, increasingly, we're seeing that improve. And each time one of us tells a personal story of our interaction, of our family members, ourselves, our loved ones, getting help and getting better from some mental illness, it makes it easier, it lowers the barriers for others to go out and seek help themselves.
Yeah, I think it's important for us to share our stories. I know before we went on the air, I shared a little bit of an illustration of how sometimes men will do anything to get away from seeking any kind of treatment, a visit to a doctor. My situation was, after my father died, I got depressed for a while, part of that grieving process, so I went and got some help, got some wonderful help. We have a lot of people in this area that are wonderful practitioners. It was beneficial. Not long after that, I was at basketball, and between games, one of the guys was sharing some situation in his life, and I thought, well, maybe he would do well to get some professional help, so I shared a little bit of my story and how beneficial it was, and then I said, you know, if it was something physical, you probably wouldn't hesitate. Like if you broke your leg, you probably wouldn't hesitate to go to the doctor. And his response was, well, depends upon how bad it was broke. So I think that shows how some men just won't go. But it's important, I think, for us to share our stories and to model, just as we would for our kids, but model for each other and give each other permission. You mentioned the prevalence of depression. And recently there's certainly been some tragic headlines. Robin Williams, the Vermont Law School professor, Cheryl Hanna. These were examples of deep, deep depression, probably on the level that they say Abraham Lincoln suffered from, where couldn't get out of bed for weeks. What is the prevalence, just focusing on depression now, among the population? He said,
well, over the course of our lifetime, it's 25% of people will experience depression. It is very common. And many people will have only one episode of depression. Not everyone has a chronic recurring illness, although some do. And most people respond to the first trial of therapy. Either talk therapy with a therapist, medication, both. And yet, when we look at untreated depression, the stakes are very high. You know, as you mentioned, suicide is a natural outcome of untreated severe depression. And it is somewhat preventable, and that's why I do what I do. It is not always preventable, and the heartache that I have for clients I have known, for people in my life, for the friends of my clients who've died, just the countless tragic stories of lives cut too short, can be overwhelming at times. And yet we know many things that we can do to make more safety in the moment. You know, one myth about suicide is that people who wish to kill themselves are fully intent on dying and will find a way. the data is that that is not true at all. Many suicides are rather impulsive. People have only, somewhere between 1 minute and 20 minutes of deciding before they act. Most suicides are within that realm. So if you wish to intervene and help protect someone, offer support, limit their access to something lethal, you don't have to do it indefinitely. You really only have to do it for a little while.
Yeah.
And then they will change their minds, or they will have the ability to see that that is not the only option to get out of the suffering they're feeling.
Yeah. What can people look for to have a sense that someone's in trouble?
Well, that is a great question, because one of the best ways to intervene and prevent suicides is to educate the community about the signs of depression, because it is the most common mental illness among people who kill themselves. The signs of depression are low mood, sadness, irritability, decreased energy and motivation, sleeping too little, sleeping all the time, a marked change in appetite, usually a decrease in appetite, sometimes an increase, and certainly talking about death or dying. Anytime you hear that in someone you know, it must be taken seriously. There is a phrase of a suicidal gesture. We aren't very good at judging someone's intent, and they may not choose to tell us their intent. So even as a psychiatrist, I don't feel like I am really seriously able to know what someone wanted to do. There are certainly risk assessments that we learn to do that can try to tease apart all of the issues that can point you towards this was serious versus it wasn't. But any time that you hear about suicidality, the first thing to do is listen to that and stop and tell someone that you care. You can save a life just by that. There are many people who've said to me, I was planning on doing this to kill myself, but I told myself, if just one person looks at me, or if this person picks up the phone, then I'll know. They're looking for a sign. And so why not be that person? If you think someone is depressed that that you work with, just go to them and say, I care about you and you look down. You think you might be depressed. Can I help? I'd like to help. I'll help you get through this. So that's really key.
That human connection is...
Show you care.
Yeah.
And if someone says that they are feeling suicidal, what I will often say is, I don't want you to die. It's a sincere, I can't necessarily make anything in particular happen, but I can let them know you're an important person. And you might not feel that way right now, but you're important to me, and I'll stick with you.
Is there a next step after that?
There is a next step, which is really get help. So depending on who you are, determines where you go for help. So if someone lets you know that they are suicidal in that moment, then you don't leave them alone until you get them to someone else who can help. If they have a therapist, you might bring them to that therapist. You might bring them to their primary care doctor. You might bring them to the emergency room or to a crisis center.
Is there a phone number, people? 911 is...
911 works. There are 800 numbers, and we'll flash some of that information on the screen for viewers around hotlines and talk lines. But 911 always works. And all I would need to do as a caregiver is sit with that person until help arrives. And that often, it's not often that intensive or dramatic. Another way might be a person just says, I'm depressed, and I recommend they get help. Well, what I should do then is follow up. If they say, I'm going to see my doctor, I have an appointment already on Thursday, then I should call them on Thursday night and say, did you tell them you were depressed? I'm reminding them how much I care. And if they say, well, no, I didn't, I focused on, my toe, then encourage them to say, well, you want me to come with you? I'll come with you. And, the inconvenience to you is so small next to the benefit. We as lay people can save lives and must if we're to stem the tide, because data-wise, many people don't know this, but in this country, there are twice as many suicides as homicides. twice as many.
Yeah.
You know, we have networks of services in this country to try to prevent violent crime, including homicide. But it's only half of the suicides.
I've been working with the local and now statewide group Gun Sense Vermont, which we're trying to prevent preventable deaths and update our gun laws so they reflect the 21st century we're living in now. One of the things we've really uncovered that was news to us was just what you shared, is the prevalence of suicide right here in Vermont too. Most gun deaths in Vermont are from suicide, mostly men. It seems, and I think I was reading, and I'll ask you if it's correct, that the reason more men are successful while more women attempt suicide is because they use a firearm.
Yes, because the means they choose are more lethal. Vermont's actually at the bottom of the third quartile. So of all the 50 states, we're almost in the lowest quarter. And that is true of many rural states. Suicide rates tend to be higher in rural states because there's easier access to treatment, we think, in more urban areas. Suicide rates tend to be higher in predominantly Caucasian states, which Vermont is. And there is a culture of access to firearms. There are other means people choose. And, you know, it gets to be tricky. I'm not here to tell anyone politically what they ought to do. But the things that I've seen in clinical practice, for example, are that I will ask a teenager, where are the firearms in your house? And where's the ammunition? And how do you get to them?
And are there gun locks?
Right. Which was, you know, are they locked? Is it a combination? Is it a key? Where's the key? They know everything. And then I ask the parents and say, does your child know? And they'll say, oh no, they don't know any of that.
Yes, they do.
And then I'll say, well, here's what they told me. They said the keys were in this drawer, that gun is actually loaded, and it's, you know, on top of that bureau, and you know, this and that. And the parents' eyes will widen, and I'll say, boy, you know, we're pretty lucky that we're all here to tell this story. And your children are smarter than you are, and they have more time on their hands. So and there's real data that having a firearm in a home, regardless even of separating ammo and trigger locks and gun safes, regardless of all that, just the presence of the firearm in the home raises the likelihood of death by homicide, by suicide of everyone in that home. And, you know, there are many homes around here in Vermont, New Hampshire, where firearms are. We have hunters, we have folks who wish to protect themselves, but it is crucial to think about how to protect everyone in your home from something impulsive, especially if there's substance use, you know, lowers people's inhibition. They may do something that they would never otherwise do.
And teenagers.
And protect your teenagers and your children.
We've only got a few minutes, and I think there was a video that they wanted to fold into this broadcast as well, so we want to leave time for that. Before we go, are there pieces just about treatment in general that you'd like the public to know about, and about the retreat? Is there a number people can call to get services for the retreat? Because the retreat, I think, focuses as much on mental health issues as addiction services. Is that accurate?
Absolutely. And you know, addiction services often, folks with addictions are often stigmatized even further than folks with things like depression. So the retreat, since its founding almost 180 years ago, on the Quaker model of moral treatment, has been serving folks with mental illness and addiction. We have services for outpatients, for people who require the hospital, for in-between levels of care between a therapist and a psychiatrist as an outpatient and
by
inpatient.
Outpatient, you mean they don't have to stay there all the time, they can just go to the retreat for their treatment and then go home again?
It's just a standard kind of practice. We have therapists, family therapists, psychiatrists who treat any of us in the community through a practice that is separate from the hospital. And then we have hospital programs for adults, children and teens. We have residential programs for children and teens. We have a really amazing uniform service program for folks in fire, EMT, police. which is an intensive day treatment program, and we have other day treatment programs for adults.
Yeah.
The number to call is 1-800-RETREAT, which is 738-7328 for people like me who hate to spell on the keypad.
Yeah.
And we're open all the time.
Yeah.
One thing that I would want to add about what we do and why we do it is that we feel that there is no line of providers waiting to serve those of us with mental illness and addiction. And so if not us, who will do it? It's not fancy. I've met my own stigma when I decided to be a psychiatrist. People wondered why I would choose such a field. Like, was I not very bright? Did I not do well on tests?
Was this in medical school?
It was. Yeah. People were disappointed. Like, gosh, you could be a surgeon. Why would you be a psychiatrist? And the brain is so interesting and fascinating, and the degree of disability from untreated mental illness is so extreme, and yet so many people do well. I just heard a story recently where a person with depression that I was treating started an antidepressant, and 3 weeks into it said, "This is not working. I don't want to take this anymore. I feel the same." 4 weeks into it, called me and said, "I feel really different. I don't really understand it." 6 weeks into it said, I want to get the quote right. He said something like, "There's a lightness in my heart that I have never felt before. There is joy now."
Yeah.
And I thought, wow, what better, how much more gratifying could my work be than to bring lightness and joy to a person who's suffering?
That's a great place to leave it, I think, for today. Thank you. I mean, one thing you just mentioned the uniformed services, and we could probably do a whole show on trauma.
Oh, that would be really interesting. I'd love to talk about that.
And I just heard a radio show which featured Bessel van der Kolk and using yoga and body-centered therapies for trauma, which is fascinating to me. But thank you for coming. Thank you for taking the time. Thank you for your work and for sharing that story that illustrates, I think, what's possible in treatment and how there's lots of possibilities for healing.
Well, thank you. It's a pleasure to be here. Thanks for having me.
Thank you. And thank you for tuning in today. Thanks again to all the people here at BCTV that offer their services so we can bring the concerns that are facing Vermonters to you and bring our work from Montpelier closer to you here in Windham County. Take care. Bye-bye now.
Tell me how you stand up to stigma and help dispel some of the myths associated with mental illness and addiction.
For me, it's about just like learning and willing to kind of say, I don't know.
I think it's just important to talk about it and not pretend like it doesn't exist. I think that's probably one of the bigger issues that we have.
Being open to how people communicate and allowing there to be a conversation, a dialogue.
There shouldn't be any more shame in having a mental illness than there is in having cancer or diabetes or any other treatable illness that requires attention in order for it to get better.
I think listen to others, listen to families who've had experiences with mental health, whether they be devastating or wonderful experiences, and share those experiences with others.
Encourage them that things get better once they identify what it is and work on what it is. Find people that they can trust and know that there's many more people behind them for their success than those that stand in their way.
It's not static, everybody has issues in their lives. We respond differently and we can support one another in so many different ways.
I think the big problem is that right now, the culture that we live in, it's not okay to ask for help. And so once we make it okay, I think we'll see a lot more people ask for help.